and Dr. Marc Abla, who is the executive director. Oh, wait, are we live now? Maybe we are live now. I don't know if I was a minute ago, but I'm going to repeat myself just in case because my go live button just came on. What's up, everybody, and happy Tuesday. So excited about today's guest, Dr. Marc, not Dr., Mr. Marc Abla. I'm so used to saying doctor week after week. Not a doctor, executive director for the Illinois Chiropractic Society. And I absolutely love and adore this man. He is hands down one of my favorite people to talk to. He will say that I'm telling stories, but that is not true. I answer his calls day or night. And anytime we need to have a 5-minute conversation, it turns into 50 because we have to talk about all kinds of stuff except for the original reason for the call, no matter which one of us does the call in. So he has an incredible heart and passion for this profession. He has been an incredible mentor in helping to educate me about chiropractic in the decade that I have worked here. Because let's be honest, I didn't know a whole lot when I got started. I'd never even been to a chiropractor before. Heck, I didn't even know I was applying at a chiropractic office. Sometimes this chiropractic just finds you, and it was meant to be. And this journey has been all the better because of the amazing people I have in my life, including Marc. So Marc is here to talk to us about the Cures Act. He's been doing extensive research over the last couple of months, and I don't know anybody who knows more about this topic, its benefits to the chiropractic profession, than him. And I'm so excited to have him here. And if you haven't listened to his tech talk with Dr. Jay Greenstein and Brad Koss, you are missing out. Message me. I will send you a link because it's my favorite podcast right now. That was the plug. Okay. I'm going to turn it over to you, Marc.
Wow. So that was mostly true, I think. And, Christy is a pillar of the profession. Don't let her fool you. She knows a lot about chiropractic, and I think she's overselling who I am, but not to repeat what she said, but I am Marc Abla. I am the executive director for the Illinois Chiropractic Society. I've been with the Illinois Chiropractic Society for over 18 years. So the chiropractic profession is my profession as well. It's what I've dedicated a large segment of my life to, and I love this profession, and I love our doctors. I love what our doctors do for our patients and our patients' health, and so it's great to be a part of the process that kind of advances our patient's health. And here's the cool thing is, what Christy kind of left out is I love ChiroHealthUSA. I mean, for years and years, we would tell our members when they would say, how can we do, legal time of service discounts? And we'd walk through all of it. And really the answer was no, no, no. And typically the comeback was always, well, how can we do this? And I know most of you are ChiroHealthUSA clients, so you already know all of this, but it was refreshing when Dr. Foxworth came up to me and he said, Marc, check out this, look what we're doing, look where we're going. And it was an interesting research project that we ended up doing on our side to see if everything was, all the I's were dotted and T's were crossed. And it was great to be able to come back to our members and say, look, it looks like there is an option now. There is a pathway to be able to help your patients like you want to from a financial perspective, and take a close look at ChiroHealthUSA. We believe that they're doing it right. So it's been great to be working with Christy and the entire ChiroHealthUSA team. They do phenomenal work, and they really help our doctors. They're dedicated to the profession. And if you didn't know that, then you should be aware of it. That Dr. Foxworth and the CHUSA team is all incredibly dedicated to the profession itself, not just their own self-interest, but what's great for the profession as a whole. And he puts his time. It's one thing to put your money where your mouth is, but Dr. Foxworth really puts his time where his mouth is too, and invests his time in the profession, the advancement of the profession. So it's nice to be a part of that. So enough about who I am. You're really here to learn a bit more about this Cures Act and some of the uncertainty, and maybe you're getting conflicting information. And hopefully we can pull all this together today. And hopefully me talking with my hands isn't going to be too much of a distraction. But I promise that during this presentation, I won't fall asleep if you won't. Hopefully that'll be a good symbiotic relationship there. I know there's a lot of uncertainty, and I know there's a lot of confusion because you may be getting conflicting information. So I'm hoping we can boil all that down, and you can put things into your practice and understand exactly what's coming, what's already here, and where we're going and why it's important. So let me give you a quick history because I think it's important to know, how we kind of got here and why it seemed like all of a sudden we're just now talking about this over the last really 6 months, and why it wasn't talked about a whole lot before, especially since it actually passed. The Cures Act itself passed in 2016. Incredibly broad bipartisan support for this legislation, and was passed during the President Obama administration back in 2016. And what's interesting is the information blocking. The part that we're really talking about is interoperability and information blocking. That particular portion was Title IV. So it was only one portion of the overall Cures Act. It dealt with a lot of things research-based and research-oriented in regards to healthcare, and did a lot of different things, of which have already come to fruition. But here we are now talking about this particular portion because you have to fast forward now about 4 years after that is when the actual rules were finalized. And now we're getting into why some of this was a bit of a challenge, and why it kind of got lost in the weeds is because the Office of National Coordinator of Health. Now, ONC is what we're going to call them today. So when I use that abbreviation ONC, you'll know that I'm talking about the Office of National Coordinator of Health Information Technology. You may better know them as the entity that was really in charge of the incentive program to move doctors to an EHR platform back in 2013, 2014, that timeframe. And so for those who were getting the incentive money during that process, the ONC, it's that same governmental entity that handled that whole process. But when I talk about the ONC, it's really important. They released the rules for interoperability and information blocking. But what's interesting is they did it almost the same exact day that the public health emergency was declared back last March, is when they actually released the text. Then it was actually officially published in May of 2020, which starts the clock ticking in this particular instance and kind of got us to where we are. But if you're wondering why it kind of got lost in the weeds, although the rest of the healthcare world was talking about the Cures Act and information blocking, it was really the health IT world was. The rest of the world was, of course, talking about the pandemic and COVID-19 and the challenges it was we're facing, both your practice and our patients. And so that's how it got lost in the weeds. Well, after it got released officially in May, 6 months later is when it was supposed to take effect, which would have put us into that November 2020 timeframe. However, as we were approaching that and numbers began to climb again just before the end of the year, they decided, you know what, let's punt this thing. Let's kick this can down the road and let's push it to April 5th. And ultimately, that's exactly what they did. So they delayed the start date from early November to instead April 5th, which drove us to that short time frame when all of a sudden, really, we had to find a way to get all of our ducks in a row so that chiropractic physicians could be compliant with the Cures Act or could be prepared to be compliant with the Cures Act beginning, whatever it is, a month ago now, April 5th.
Excuse me, Mark?
Yes.
Can you stop sharing and reshare because it's not sharing your slides?
It is not sharing my slides.
No.
Oh, give me a second. And that's why you jump on, right?
It is. That because I never want to miss an opportunity to hear you speak. He has great videos on YouTube, everybody. Just saying.
Okay, is it sharing now? Are we advancing? And
we are.
Sweet. Well, I'm glad you said something. Thank you. So, and not that you need to see it all, it really is nothing fancy, but you get an idea. So when they punted it down, they delayed it until April 5th, and that's really when all of the information blocking requirements and regulations began. It was 1 month ago on April 5th, and a month ago today, I believe. So that's where we're at, and that's where now some of you may be going, well, Mark, I really haven't gotten any requests. Is this really a thing? Yeah, the answer to your question is yes. This is a very real thing. We're at the beginning, and there's always going to be a bit of a curve. And I just want to remind you this, there's always going to be a bit of a lag, if you will, this technological curve. As technology continues to catch up to the regulation and the requirements, and so does our human side of this. And as people and patients begin to realize what the possibilities and what they're allowed to do now, it's going to take hold. So, what we want to do is we don't want you to be fearful. And I want to make sure that's really clear. I'm not trying to scare you into compliance. That's not who we are as an association. It's not who I am as an executive director. But I do want you to be diligent, right? I want you to be prepared and know and understand exactly what you have to do. And so that's really the purpose behind today's webinar, is kind of give you that baseline understanding. It's not going to be able to give you everything, but it's going to give you enough understanding that you can begin to realize what sort of steps that you're going to have to take in your practice and what you're going to need to do. So that's your brief history as to the Cures Act and information blocking and interoperability. So here are really the basics for this portion of the Cures Act. The whole purpose behind the information block, this portion of the Cures Act, this Title IV, was interoperability. They want to make sure that there is an environment for records to be shared among providers, regardless of your location, your hospital system, technology used, provider status, what you do. But anybody who is in healthcare has the ability to be able to access a patient's records, to be able to make sure that that the patient is being served at their highest level, right? So that the way that they wanted to achieve interoperability is, as governments will do, is they create requirements and regulations, and they did that through information blocking, right? So the information blocking provisions really kind of shift our mindset from being allowed to share records to instead being required to share these records, right? So that's information blocking. Is anything you would do would stand in the way of sharing medical records, not just with other providers, but with the requester. And that's really important. And we'll cover that a bit more here in a few minutes, but that's information blocking, and that's something you don't want to do. So interoperability is the goal. Information blocking is the method to kind of get there. But then the hub, that central way to make it happen, is by putting the patient in full control of their healthcare record. So that's that other big piece of this regulation basic side of things, is it moves the patient to the center of their medical record, right? So since it's about the patient, then it's going to be the patient's ability, an obligation a little bit, to be able to handle their medical record and have everything associated with the medical record in their control. It really kind of moves us from being, as providers, from being the owner of a medical record to instead being the custodian of that record that you maintain and that you've created in your practice. And so that's kind of an important understanding as well. You become a custodian as opposed to an owner, and the patient's now in control of the record. All right. Now, who does this impact? Well, in this act, they call the players, the people that it's going to impact, actors, right? So the actors are really threefold. You're going to see healthcare providers, health information networks and exchanges, and then health IT developers of certified health information technology. And so those are your quote unquote actors. The vast majority of what we're going to deal with are really centered around providers and developers of certified health IT. So first of all, healthcare providers, of course, that's you, right? That's our doctors who are in on this call and listening in. And really, it's really broadly interpreted because they want to make sure that everybody is included in this, because interoperability is, remember, that's that goal. That's what we're trying to do. And so healthcare providers are in. And chiropractic physicians are actually specifically mentioned. Now, the act actually refers to another portion of code in federal regulation, and that particular code specifically talks about chiropractic physicians. So we are specifically included as a healthcare provider under the Cures Act. Now, what does this all mean? Well, remember, interoperability and patient-centered records are really achieved through that information blocking prohibition. And that's how it mostly impacts chiropractic physicians. Now, there are some things that come up here a lot when we start talking about healthcare providers, because these are the questions that I typically get. And so I want to cover some of these really quick. First of all, no, there is not a small office exemption or exception to the Cures Act. It doesn't matter if you're a single provider and you're the only person in your practice. or you have 15 locations and you have 3 or 4 doctors in each location, it really doesn't matter. The Cures Act and information blocking prohibitions apply to you. You do not have to, now this is important. In order for it to apply to you, you don't have to use certified electronic health record systems. Let me say that again because it's important. You don't have to use certified EHR systems in order for the Cures Act to apply to you. In short, it applies to you if you maintain any kind of electronic protected health information record. So if you have any kind of patient information that's maintained electronically, the Cures Act applies to you. Yes, it does apply to you even if you do not have a certified EHR system. So it applies to you regardless. So you're not you're not required to switch to a certified EHR system. You're not required to add an EHR system if you're doing paper records now. There's no requirement for that. But if you're using a system, which by the way, the vast majority of chiropractic physicians are not using certified EHR systems. If you're not using one, it still applies to you because you're maintaining electronic protected health information, right? Now, no, you cannot just simply update your policies. This is another big one that we've seen out there is just change your policies and then you'll be good. That's not the case. This isn't just something where you can change a couple of things in your policy, in your HIPAA manual, and walk away from it and not worry. It's going to take some proactivity on your part to understand, 1, what the concept is, 2, you're going to have to make policy changes, and 3, procedures for how to handle a request when they come in. And so it does impact you, and hopefully this covers you. Now, the other one that I'm going to add in here that's not listed is I get this question a lot. Okay, Mark, I use, all of my records are maintained on paper. I keep my appointment book on paper, and everything that I do is on paper. And in those cases, then the Cures Act would not apply to that doctor. In other words, there's no provisions that would be impacting that doctor. Now, sometimes I'll get this, Mark, now I don't keep any medical records electronically. They're all on paper. And I'll follow up and say, what about your appointments? And they'll say, well, no, all that's electronic and we handle that electronically. In this case, that is electronic protected health information, and the Cures Act would apply. There's going to be, there's some help for that. And those doctors are going to get a little bit of a temporary reprieve, but it still applies. And that's important to understand. I'll cover the reprieve here in just a few minutes. But yes, it applies to you. Most likely, most of you on this call, it's going to apply to. And it's important to know that right up front. Health information exchanges and networks. Now, this is another quote unquote actor under the Cures Act. So, health information exchanges and networks, if you're not familiar with what they are, they become clearinghouses for medical records. So this is a great way that hospital systems a lot of times exchange health information. So they'll participate in a statewide health information exchange. And then at that stage, their records, once they're saved in their EHR, and typically are automatically made available on the health information exchange, and other providers who are going to help that patient then have access to those records. Again, it becomes this kind of central location, easy to maintain, an easy place to be able to tap into a patient's medical record and have more information. Again, remember the key is interoperability. And networks are pretty much the same thing. So, and really just getting down to the elementary, they're very similar in nature. Now, what does this really mean? Well, that means that they're also covered under all of the information blocking prohibitions. So they can't do things that would restrict the access to a lot of these records. So chiropractic physicians sometimes have not been able to participate in health information exchanges in different states for various reasons, political typically. And in those particular states now, under the Cures Act, they can't be excluded, right? Because health information exchanges and networks are included as an actor in this particular case, they can't prevent you from accessing that. Now, additionally, they also can't prohibit you or keep you from actually participating or contributing medical records to that information exchange and network as well. So if your system has the capability, a lot of systems don't, but if it did, they couldn't tell you, well, because you're a chiropractic physician or a chiropractor, you can't participate in the health information exchange. and they can't do that. That would be prohibited under the Cures Act. So it's got a very positive impact for chiropractic physicians. It means that we can tap into potentially a resource that we haven't been able to in the past. And I've seen this in action. Had a great conversation with Dr. Chris Anderson out of North Dakota, and he walked me through some of their health information exchange and how that all plays out, and how he's able to better help his patients because he has more information via interoperability and their statewide health information exchange. And it really is good. It's great for the profession, good for the patients. Now, the last key player here are IT developers. Now, it's really important to note that there's a distinguishing difference. They actually single out a particular type of health IT developer, and that's health IT developers of certified health information technology. That means if they're developing a system that isn't certified, and there are a number of them out there, then it doesn't cover them. It gives no and creates no obligations for them. But once they're certified, then they have all of the requirements under the Cures Act, and all of those requirements apply to them, including the penalties. And the penalties are significant for IT developers. In fact, significantly more than they would be for providers. And I'll cover that here in a few minutes as well. So what are some of the requirements for the developers? Well, it requires a common data set. And in other words, standardized, language and fields and specific things that have to be included. It requires an API. And if you're not familiar with that is, single sign-in type things you may have where you can sign in through using your Google account or your Apple ID, or maybe use Facebook or whatever the case. That's a form of API or application programming interface. The other way is that actually a lot of information is traded through APIs, and that's why it applies to them and why it's important. And APIs are a requirement under the Cures Act. Also, and this is really important, this is really cool, for certified systems, they're required to allow for a full export as of 12/31/2023, which means that changing and modifying, if you want to switch EHR systems, you may not be handcuffed to a particular system anymore because you would have the ability to be able to download your patient records and pull them up into another system. But that's another requirement of IT developers of certified health IT under the Cures Act. So just kind of giving you an idea, those are the players, providers, and healthcare providers and health information exchanges and networks as well, and IT developers of certified software. Now I'm going to kind of cover back to the basics a little bit and cover a bit more in depth interoperability, information blocking, and things along those lines, because we need to have this really good understanding so we know how it applies to our practices and what we have to do and what steps that we have to take, and understand also how these requests are going to come in, because everything is based on requests. And again, remember, interoperability is the key. So we want to make sure that the patient's records are exchanged well, that they're up to date, and that each provider has the greatest amount of information to be able to help the patients, right? So it's good for us as chiropractic physicians because we can better help our patients if we understood more. You don't have to rely on a patient remembering what their other healthcare providers have told them. Instead, you can look it up in the healthcare record and know precisely what other things have come into play with that patient since they were last in to see you. A quick illustration for interoperability and the importance, we've got a neighbor who recently was diagnosed with a form of pancreatic cancer, and when he was seeing one of our local providers, a local oncologist, they sent him off for a particular radiological study, and went to the radiologist, and ultimately what happened was they missed it. They missed the diagnosis. They missed it significantly. Ended up down in Barnes Jewish down in St. Louis, Missouri, where they were able to find it, tackle it, and take care of the problem. And he's doing great, by the way. But what ultimately happened is when they were questioned, when the oncologist got questioned, they said, well, look, hey, this isn't my fault. There was no way for me to know he had this particular issue. It's the radiologist's fault, which I thought was interesting. I threw the radiologist under the bus. Of course, then when they asked the radiologist said, I didn't know what the patient's symptoms were. Since I didn't know what the symptoms, I didn't know what his issues were, I had no idea what I was looking for when I looked at the film. That's a really good case and kind of an example of the need for interoperability. Had the radiologist had access to the oncologist record and saw exactly what the patient was having problems with and the challenges the patient was having, then ultimately a lot of this would have been averted. They'd have found it months earlier than what they did. And maybe he wouldn't be, he wouldn't have had some of the challenges he had having to wait those extra few months. And so interoperability is really a key. Now, of course, that's a grave circumstance, right? But I think we see it also in our practices, sometimes on the minor scales where patients just forget some things, right? They forget that maybe their meds changed, and so it's creating some other challenges in regards to some of their musculoskeletal issues that you may be treating, or if you're a nutrition doctor, some of the nutrition challenges they may be having. And so any of these things could come into play. With better interoperability, we can always do better to help our patients. So the key is this, right? The main concept is with good interoperability, there really is no human intervention. Instead, there is this secure electronic exchange of health information, and that's key. Now, what are the problems that are solved through interoperability? Well, faster access, more informed diagnosis, broader research, increased quality care, and reduced errors. I gave you an example of reduced errors, higher quality of care. You know more about the patient. You know more of the other issues that maybe they're seeing another provider for, that maybe they've forgotten or they're just simply not telling you. And so all of that is key, right? All of that's really important, and why interoperability is such a key component and one of the basis, if you will, of the Cures Act and the information blocking prohibitions. So what are the benefits of the chiropractic profession? Well, because we're specifically included, then we are specifically included, right? We always want parity. We're looking for that parity. That's why we're chasing, the new Medicare bill, which is House Resolution 2654. And so ultimately, but we want that parity. We want that inclusion. And in this case, chiropractic physicians are on an even playing field. We're fully included in the Cures Act. So sometimes we look at this and we go, man, I wish we weren't included. I wish we had the exceptions. I wish we had the exemption. I think the good part about this is we are included, which means we do have access to more information to continually help better our patients and improve their overall healthcare status. And that's really what we want. We want our patients to be healthier. And the other big benefit to the chiropractic profession is big data. With the availability of the information and the broad applications that can be done, the amount of data that's going to be out there, the data lakes and research, the capability is going to be huge. If you're not a big data analytics person, I will tell you that that's really the way of the world. That's why insurance companies wield such powers. They have all of the information, right? They gather everything. They can exchange and trade a lot of that information, and they do. This gives us an opportunity to be able to seize a research opportunity instead of doing 5, 4, 8, 1,200 person studies. We can do 50 million person studies where we're analyzing a particular condition to clearly, continually, even more so demonstrate the efficacy of chiropractic for our patients, and demonstrate to major carriers and healthcare decision makers the importance of having healthcare. Our chiropractic is a part of a patient's healthcare team, and the more that we can get to the more information we can get to those decision makers, the better it is for the chiropractic profession. We already know the benefits, right? We see this. We know what the research says, but having this massive, huge big data analytics opportunity is something we shouldn't pass up, and it's going to be huge for the chiropractic profession. Really looking forward to that, as well as the financial efficacy, not just the efficacy to the health of the patient, but also the financial efficacy that we're going to be able to clearly demonstrate using this big data opportunity. Now, information blocking. Well, the way that they defined it under the Cures Act. So we just covered all the interoperability and the importance and the benefits. Now, information blocking. Well, this is a practice that ultimately that a healthcare provider knows is likely to interfere with, prevent, or materially discourage access, exchange, or use of electronic health information. Now, I'm not trying to insult your intelligence by just reading to you, but I think this one's really, really important. You have to understand it's likely to interfere with, prevent, or materially discourage access, exchange, or use. So you can't interfere, prevent, or discourage access, exchange, or use of a patient's electronic health information. And that's key. Well, and really, not just a patient, right? It could be the request could come from outside sources as well, depending on ultimately how this all plays out over time. And we're still, remember, we're still in the infant stage in that first 1 month time frame. And as time goes, we're going to see more and more how this is going to play out. But it's key to understand that information blocking is considered, you don't want to interfere with it, you don't want to prevent it, and you don't want to discourage access, exchange, or use of that electronic health information. It's really important. Now, what does this ultimately mean for us, and what can we kind of boil this down to? Well, HIPAA kind of set the standard that allows, it kind of gives examples and timeframes when it's okay for you as a healthcare provider to share protected health information. So in other words, you're allowed to share protected health information in certain circumstances. The Cures Act shifts that mindset to you're required to share the information, except in certain circumstances. So you're allowed to over here, and now with the Cures Act, this is the biggest shift away from HIPAA. It doesn't replace HIPAA. I want to make sure it's really, really clear. It clarifies where HIPAA allows it. That allowance is still in play, right? The Cures Act now requires the sharing of that information, right? Except in certain circumstances. I know some of you are probably going, wait a minute, Mark, what about? There are some exceptions. We're going to cover those, but they're limited and they have to be applied on a case-by-case basis. We'll talk briefly about those. We can't go into full in-depth about all the exceptions, but I'll cover that in just a few minutes and hopefully walk you through what some of that looks like. By the way, if you have any questions, you can go ahead and chat, drop those into the chat box. And if it's something that I'm not going to be covering later on, we'll try to cover it kind of in line. Christy will help me out and let me know if I can further develop on a thought. Or we'll just cover all the questions at the end. We'll see how that shakes out. But yeah, go ahead and type your questions in the chat box. But hopefully this gives you an idea of the mind shift behind the Cures Act, right? So the question I get then is, okay, what information has to be shared, Mark? Well, here it is. All electronic protected health information. So this is where the Cures Act actually points to HIPAA and said, HIPAA defines what protected health information is, right? We're saying anything that's electronically stored that is that protected health information or EPHI, that is covered under the Cures Act and has to be shared. That you cannot information block those particular items, right? So you can't do that. So what does that mean? Well, it includes medical records, billing records, appointments, both past and future, lab results, x-rays. X-rays, again, you remember, all electronic. Some of you are going, wait a minute, my x-rays are all on film. No, it's electronically stored, electronic protected health information. All right, so that's really important to understand. X-rays, all information used by providers to make decisions about patients. And that's why it's broader than just your EHR, right? It's broader than just the record or your charts. Instead, it includes every facet of the patient that is protected, the protected health information. And that is included as long as it is stored electronically. Really, really important, all right? Now, this is where we get a bit of a reprieve. So yeah, it includes all of these things that are kind of highlighted down here at the bottom. But what's interesting is the ONC said, okay, we also want to be reasonable in this. And so, by the way, if you haven't seen this is straight from the ONC. This is kind of their timeline, and you'll see what all the different keys are. You can see what some of the items are for the different actors, right? So, health IT developers of certified EHR or certified health IT. All of those things come into play. But here are the two key things that I want to point out right now. One is here's the applicability date for information blocking is a month ago, right? And then this is important. The electronic health information definition is limited to electronic health information identified by the data elements represented in what's called the US CDI. Now, I don't expect you to know exactly what US CDI means, but I'm going to touch on that in just a second. That means that instead of all of that information that I just talked about a few minutes ago, as far as health record, or as far as their appointments and other stored information, or your practice management or patient management software, whatever the case is, things that are maybe outside of your EHR system or away from your charting system, whatever it might be, it's more limited than the all-inclusive definition that I just gave a few minutes ago. Instead, what they said, everything that's represented in the US CDI. So here are the main headers for the USCDI data that now is required to be shared, right? At least for the next 18 months. And I'll cover that in just a second as well. But right now, as of April 5th, these are these key items that have to be shared. Okay. Now, if you want to see a full breakdown, I can give you, there's a shortcut right there, ilchiro.org/USCDI. And that actually takes you right to the ONC site, where you can see the full USCDI data set and see all the different little nuances of each one of these things. But you'll see it's more than just your standard EHR elements. In fact, if they haven't updated, even certified softwares have to have a new Cures Act certification. And once they do, then they have all of these elements. But there's a few elements in here that actually are not included in the last required certification for certified software. And so there's a bit more now under the Cures Act. In fact, there's a different level of certification that can be searched. And at our last search, I will admit it's been a couple of weeks, so maybe some have been added. We don't believe that there's any chiropractic specific EHR system that is fully Cures certified under the ONC. Now, again, that could have changed over the last couple of weeks. That was at last check. But that kind of gives you some ideas of what is required right now. Now, and we go back over here now to this chart, and we're gonna look down at this other part in that bottom right-hand side. Now, this is that next date. So between April 5th and October 5th of 2022. So a month ago, all the way up to October 5th of 2022, we have the limited set that I just talked about a few seconds ago, this piece here. But now we're going to zoom in here. Now it's no longer limited to the USCDI data set. Instead, it's everything. That means it's your patient management software. It's your it's going to be information that may be contained in appointment keeping and appointment making software that you may have, whatever it might be. And this is another key component, your billing. And that's the other side of things. I've had it where doctors keep their appointments on paper. They keep all of their charts on paper, but all of their billing is electronic. That would be included in this data set. That means as of October 6th of 2022, it's everything. It's not just limited to the other data. And so it's really important to understand and know that it's very broad in its definition. All right. So now I mentioned the exceptions. So, because I know some of you are going, okay, Mark, but what about privacy? You know, HIPAA covered privacy. We've had privacy drilled into us. Quite candidly, I don't have time to even go into the details of these exceptions because the devil is in the details with the exceptions. And we've got some information, hopefully, that'll help many of you out on this. But instead, I want to make sure that you know that it doesn't replace the privacy needs of a patient, right? So there's a preventing harm exception. And there's also a privacy exception. This is key. This is where they defer back over to HIPAA and say, HIPAA still applies. And you may have state laws in your state that have more stringent restrictions than even HIPAA does. Those are also still in play. You still can lean on those requirements by your state or by HIPAA. But at the end of the day, they have to be on a case-by-case basis. And you have to know, right, that you're going to be violating the patient's privacy. So you have to be careful because you don't want to do anything that prevents, right, or even materially discourages access use of that protected health information, right? So privacy, security is exception, which is going to be very limited in scope to most of our doctors. The infeasibility exception, which will apply to many of our doctors, but not all of you, and it's not a blanket. There are requirements under that are really restrictive and must be done on a case-by-case basis, meaning each time you get a request from a requester that you have to deal with that. Health IT performance exception, very limited in its scope, won't have much of an impact to many of our doctors as well. Now, this is really important. These 5 exceptions, so there's 8 total exceptions. These 5 exceptions are really exceptions for when it's acceptable to not share the records, okay? But the next 3 exceptions, these are more procedures. I don't know why they call them exceptions, but they kind of put them under here. But these are only procedures on how you're going to fulfill the request. So you may have heard, you may have heard from different players out there that, oh, just use the content and manner exception to be able to not give records. Well, that's not what the content and manner exception is designed to do. Instead, you actually have to go through a quote unquote negotiation with the requester when you get that request on how you can fulfill that request. That's what the content and manner. So the content portion of this exception deals with that limited data set that we talked about for the first 18 months. And the manner exception is how, the manner, the way in which you're going to give them the information. Again, I don't know why they called them exceptions, but this is what they called them. And so we go with it. The fees exception and the licensing exception really aren't going to apply, because here's one of the key emphasis points of this is the patient gets access to their records at no cost. The patient gets access to their electronic health records at no cost. And that's one of the key base foundational concepts behind the information blocking. But ultimately, again, remember, these are procedures about how you fulfill the requests that come in. Hopefully that helps at least kind of give a baseline. We don't have time to go through HIPAA. That could be a 4-hour class in and of itself. And of course, there's a full another hour class on top of this when we start to cover all of the exceptions for all of these pieces, which include, just know that they're there and it is a possibility, but understand that blanket policies in your practice are not going to fulfill the requirements under these exceptions. They have to be handled on a case-by-case basis. So you need both the policy and know that you're going to have, that interaction, if you will, when the requests come in, unless you have a system that handles it for you, right? So many systems can handle it. And that's what the API is for. And it makes it seamless and less work for your practice. But I'll cover that here in just a minute. Now, how must the information be shared? It has to be shared in the manner in which it's requested. I want to say that again. It's really important. You must share the information in the manner in which it's requested. That's where that content and manner exception came in. It's the procedures and walkthrough. If you can't give it to them exactly like this, then this is what you have to do on a case-by-case basis. But the standard way that these requests are going to come in are going to come from an API request, right? So typically they're going to ask your system for the information. And if your system can do it, then fantastic. You don't have that human interaction. There's a way for that system to share it appropriately. That's what that API, that application programming interface, is for. And so that's how a lot of that's going to be handled, is through API, right? Unless an exception applies, right? And in those cases, that's where you'd handle those on a one-off basis. So, but it's really important to know that ultimately, as you walk through that content and manner and how you must share it, each one of the steps at the very bottom. So in other words, they're saying, okay, if you can't do any of that, then you still have to do this. And that is that you have to make it available in an XML format. Okay. In an XML format. Now, is there a way that allows you to kind of, after you've gone through all of these steps, if it's just simply not possible, then it would be potentially possible to use the infeasibility, but you have to, every single time a request comes in, you would have to go through each one of the steps and negotiate with the requester. But the very bottom is an XML formatted file. And if you don't know what that is, it's not human readable. And remember, this is not, the sharing of this information isn't designed for a patient to be able to just look at whatever you share. That's why just a simple, PDF of your documentation isn't going to cut it to be able to fulfill this unless the requester says that's okay. Instead, it has to be done in a computer readable format. That's the baseline, right? That's the worst, that's the worst of all cases. In other words, if you can't do any of that, you can do this. It's still XML. It's an XML. The patient isn't going to be able to read it. It's designed for computers to read it. In fact, that's what it's called, computer readable format. All right. Now, all of this, you may be sitting back and going, I just don't understand, why on God's green earth are we doing this? What's the purpose behind this? And this is a really good quote from Don Rucker, who is the actual national coordinator of health information technology. And there's just a couple of things that I want to point out inside of this quote. They want the patients to be able to control their electronic health information. They want them to be able to use the tools that they want to use, meaning the patient. And they really want to allow it to be done through apps. And this is really important. So patients control the tools that they want via apps. And so you're probably sitting back and saying, what do you mean apps? Well, all right. So this is kind of an interesting dynamic, because some of you who went through the whole ONC incentive plan a handful of years ago and got your incentive money, one of the requirements is you had a patient portal, right? So you're sitting here going, Mark, I had the patient portal. Nobody used it. Or I had 2 patients download it and 1 person use it, or whatever your statistics were. I heard it time and time again that nobody was using it. Well, here's the reality of the current situation. That was 2014. So we're talking 7 years ago. Just to kind of bring things into perspective, TikTok, if you're familiar, and maybe you don't care, but I just kind of giving you perspective, TikTok didn't even start until 2016, and now over 1 billion videos are viewed every day on TikTok. And so it kind of gives you an idea. And I know what you're saying is, well, TikTok's not health apps. You're right. But what we saw was an continually increasing usage of health information applications by patients, apps, right? Until COVID hit, and then it just exploded. And through a variety of ways, people went and got tested, and many times they were notified, and they got the results faster through their app than they did through the provider who was giving them the results. And so they got the information faster. And ultimately, what hospitals started doing is not even bothering contacting the patients if they opened their app and saw the results in their app. And so it actually lessened the burden on the providers to make contact with the patient, if they were positive or negative or whatever the case is, because the patient got the information more quickly through their patient app. So there's a couple of examples that I like to use when I start to talk about this, but most hospital systems, and it's just a market share game, most hospital systems use Epic, and Epic's patient app is MyChart. So many of you probably could pull out your phones. If you're from Illinois, I can almost guarantee you can, because almost every hospital system in Illinois uses Epic. Almost, not every one of them, but almost. And so almost all of the patients have MyChart on their phones. And so if you want to kind of get an idea of some of the interoperability things that are already in play right now with MyChart, they're already out there. You can go take a look at it, open up your phone, pull up the MyChart app, and take a look at some of the interoperability things that are already in play. You can see the patients you can track appointments, and you can track all of these different things. And ultimately also, you'll see in there is a button that says share with a healthcare provider all of your notes and information. Give them one-time access through this button. You click this, you key in the information. The provider gets an email, and all of their records are instantly available. By the way, that's something that you can use if your primary healthcare system in your area, a hospital uses Epic, and your patients have MyChart, and you want to get access to the records more quickly, ask the patient to click the button and send you the chart. And it's a faster way for you to get access to the medical records from a hospital system. And use it, right? Well, let's use this thing to our benefit. The button's already there in MyChart and active for patients. Sometimes it's a big button. Sometimes they have to access the menu in the upper right-hand side, whatever the case is. There's a variety of different ways. But MyChart is a pretty good example of exactly how some of the interoperability things are going to happen. And as this progresses, the interoperability between these apps is going to explode. It's going to increase because that's what people want. To give you an example, if you weren't aware, Apple has a health record app. In fact, it's called Health Records, and you can go download it right now from iTunes, from your Apple store, right? And you can get that information, and they're getting into the game. In fact, I think last count, there was like 36,000 health-related applications in the Apple store. And so this is a growing it's a growing demand, if you will, and the more apps that are out there that have a lot of this functionality and have these medical record functionalities built into them, the more competitive it's going to get, and the more features that people are going to add, and the faster it is. In fact, you can see right here in Apple Health Records, you can see the picture on your screen. You can see access, connect your provider to see your health records and get updates when there's a new entry. You get started. You click a button, and all of a sudden it begins to tie everything together. So you can kind of see where this goes. And you see how this goes by looking at maybe some other example apps that you may use on your phone. I use TripIt. If you don't, maybe you don't use something to help you aggregate all of your travel information, but I use an app called TripIt for travel. And so whenever I'm traveling and I get a confirmation email for a hotel or for a flight or whatever the case is, my TripIt app sees it, comes in through the email, grabs it, pulls it in, adds it into one-stop shop. So I can go click on one thing and see every bit of my travel information for a trip in one location inside my TripIt app. But then it also communicates back to my Google Calendar, and it puts it all in my Google Calendar as well. So I get all of that information. Now, I because I'm an association executive director, I travel with different board members at different times. And so when they send me their travel information, it also adds it in. So I have it all, in one central location, and it's nice. It's all organized. It's easy to use. You can see where some of that is going to play out for our patients. And what we see with that is, with our patients, is they're going to be able to track all of their appointments, all of their healthcare appointments. So they can key in your appointment in there, right? So you can see this, get started, and they key in your name, and then it pops up and asks them, right? So they key in your name and contact information into their health app, and it pops up and says, would you like us to request some medical records on your behalf? And so they do, right? And so now you're getting the request from the app on behalf of the patient, right? And now you're faced with this, and you've got to do the negotiation unless you have the API, and some of that'll be a lot faster in its connection capabilities through that API. But otherwise, the challenge is you have to handle that, and you have human intervention. So now you get the request, you work through the negotiation, and let's say you're able to fulfill that request, and that's great. So now you fulfill the request, and everybody takes this deep breath. And now all of a sudden, the patient has an appointment with you on Wednesday, tomorrow, right? And so they come in and see you. On Thursday, it pops up with a notification that says, we want to make sure that you completed your appointment with Dr. Smith. And the patient says, yes, I did. Would you like us to request the records for that visit? Yes, I would. And now you get another request. And so ultimately, this is what we see coming as a possibility. Is it here today? I don't think so. I haven't gotten any calls from any of our members, and we usually do. When things like this start to really happen, it starts to ramp up. But you can see how easy it is for the apps to be able to add these features in. And as soon as one does, then they all will, because it's a highly competitive marketplace, right? And so this is how we see the problem and the challenges that are faced, that our doctors are going to be faced with in handling these through human intervention, and why we believe it's important to have a system that's going to be able to handle these on your behalf, right? And so if it can handle it through API and you don't have the human intervention, then it's going to be a heck of a lot easier than if you have to deal with these and negotiate, quote unquote, which is what the act requires, negotiate with each individual requester. And so we see how this is kind of playing out, but it's all going to play out through apps, and that's the intention. So how long do you have? Well, actually, the Cures Act doesn't change the time frame, right? The HIPAA's time frame still exists. So the time frame right now is 30 days under HIPAA, but that's the outlier, right? That's the longest it can be. I will let you know that actually CMS actually released new rules for HIPAA that they're trying to get implemented. It's under comment period right now. And in fact, I think the comment period is ending over the next couple of days. That's going to shorten that time frame down to 15 days. We'll see how that plays out. But my guess is within the next 12 months that time frame is going to shrink down to 15 days. But that's just what's looming, not necessarily what's here right now. It's 30. But the key is this. They have indicated that their expectation is that responses will be faster when you're using health information technology, right? So you don't want to stand in the way. You don't want to take your time. In fact, if you don't think you're going to be able to do this in any way, shape, or form, you actually have to move more quickly, because you're required to respond within 10 days if you're going to exercise the infeasibility option. But that requires that you go through all the negotiation first. And so that's really important to know, that really there isn't necessarily a sped up time frame unless you just can't do it. And there's no way to do it. There's no functional way to do it. You still have to negotiate. Remember, it can't be a blanket policy. You're still going to have to negotiate, because you may be able to come to an agreement to give them something. But otherwise, it's going to shorten that time frame, because you have to notify them in writing within 10 days if you're going to exercise the infeasibility option. But that's a topic that's a bit more complicated, and I'll give you some resources for that here in a little while. HIPAA rule still applies. I just mentioned that. Yeah. So there's how long you have to fulfill the request, right? So now, what are the penalties? Because this is the thing. And this is why I said, we don't want you to be scared. I want you to act in fear. We just want you to be diligent, right? And so what are the penalties? Well, for providers, OIG will refer information blockers for disincentives. Now, if you are, let me do this. If you're on the call and you're a MIPS doctor, this is going to apply to you, and it could be potentially significant because you'll be if you don't comply or if you information block, you'll be referred for disincentive and it'll have a direct impact. Now, if you're sitting on the call, which is going to be 99+% of our doctors who are on this call, if you're sitting on the call and you go, I don't know if I'm a MIPS doctor. You're not a MIPS doctor. If you're asking the question if you're a MIPS doctor or not, you're not a MIPS doctor. It only applies to a certain subset of high volume Medicare doctors. And in those particular cases, then you wouldn't be a MIPS doctor. And what I typically tell our members is this: if you're wondering if you're a MIPS doctor, then you're not. If you are a MIPS doctor, which is the merit incentive based program, so it's a program surrounding incentive based on a merit system. So you do this and you get rewarded for it. And but you've been notified by CMS that you're a MIPS doctor and you fall within those requirements, and you have different subset of requirements. But again, it's a very, very small fraction of the chiropractic profession. And most likely, most of you, if not all of you on the call, are not MIPS doctors. So don't panic about that. But I do want our MIPS doctors to at least know that. Now, for everybody else, what does that mean? Well, right now, probably not a whole lot, and there probably isn't a whole lot. So it's akin to almost putting up speed limit signs and even getting pulled over and then really not having a whole lot of significant consequence. But that's also not a reason to not be diligent, because they have said that they're going to address civil monetary penalties for providers in future rulemaking. So we already know it's coming. They're going to add on penalties, but that's in the future. Right now, it's just all about disincentive, and which is a lowering of Medicare payments, and only for the MIPS doctors. There are potentially some other issues, but I think that those would be in extreme cases. And really, I don't even want to go into that because I don't want to generate fear. That's not why we're here today. So what other things? Well, if you're a health IT developer of certified software, then your penalties could be $1 million or up to $1 million per violation. It's really important to understand. That gives you an idea of how serious they are about interoperability and information blocking, right? Now, this middle part is really untested, and this is a standard of care. Here is the thing. The rest of the world is doing this, right? Because the rest of the world, the rest of the healthcare world, so your hospital systems, your MDs, your PTs, they're using certified software. Your optometrists and podiatrists many times are using certified software. And so because of that, then it's generating and creating kind of the standard of care. Now, we haven't seen this testing in courts, of course. It's only started a month ago, and we really haven't seen a whole lot in the way of information blocking. We think they're going to be slow to really go through enforcement anyway, at least over the first 6 months or so. But it doesn't mean that it's not in place and against the law. The speed limit signs are definitely up, if you will. But the standard of care is being established, which means ultimately if you're not, or if you do information block, although the penalties may be small, you may be in violation of your state statute that requires that you follow standard of care, right? And so be careful that you don't just ignore it and walk away from it because the penalties don't really matter. Don't do that, right? Be diligent and begin to put this into process and put this into plan for your practice, and know how you're going to handle these requests and handle them appropriately when they come in, so that you don't run into a standard of care problem more currently. So what's the impact? This is interesting. So the impact really is, and we've covered a bit of this as we've gone on, but on practices, well, there's potential time impact, right? If you're not using certified software, then you're going to have an inefficiency challenge in your practice, because it does require human intervention, right? It's going to require that you negotiate with the requester each and every time it comes in. I kind of gave you the progressional process of probably how some of these requests are going to come in, right? One initial one, and then one for each time that the patient visits after that, just by clicking a button. Happens really, really simply. And that's where human intervention and efficiency and inefficiency come into play, and that's not good. Now, on the good side, you have portability, and I mentioned that earlier, right? So you're able to export all the HI that you produce electronically and manage. Why? Because they want you to be able to switch health IT if you want. They don't want you to be stuck with a provider who may not be providing you with the service level and the software that you need for your practice. So they want that portability of your EHR, your records, if you will. And I think that's very, very good for the practice, right? So what about on patients? Well, improved healthcare experience, greater control of their information, and increased choice in patient-facing apps. So the more that we move this direction, the more that they can choose an app that's going to serve what they really want it to do for them, and how easy it is to click and share their information with their doctor. Because again, at the end, the primary baseline goal is that interoperability so the patient gets better care. And you can think about, some of you may have elderly parents that you want to help, right? This is a way that you can functionally help them and make sure that all the doctors know all of the challenges that they're facing to make sure that they're getting optimal care. And for your patients, the same thing. The more care that you have for them, the better. Now, what about for you, particularly as a chiropractic physician? Increased interoperability is going to give you more patient information and current treatments of other provider. More information equals better outcomes. You have greater inclusion and parity. We always want parity. And unlimited research capabilities. The big data analytics is just going to be tremendous for the profession. And we talk a lot about this on the podcast that she mentioned earlier in the session, Tech Talk with Jay Greenstein and Brad Koss. Those guys are phenomenal, brilliant people, and talk a lot about data analytics and big data. And encourage you to check out that podcast. But that's really where we're at. That's today's coverage. Kind of gives you a good overview. If you want more information on the Cures Act, you can jump out to ilchiro.org/cures. You can see a couple of videos that are available, shorter than this, of course, and then obviously some other things such as 4 articles that kind of walk through a lot of what we talked about today. But the 4th article is really key, which is more the how-to. How can you really implement that? Also, check with your state association where you're located. They have resources as well for the Cures Act. Check with them and see what they've got for you. That may give you even more information in regards to how you can implement this, taking into consideration some of your state laws, especially surrounding privacy. Christy, what do we have in the way of questions?
We have a couple. So does this apply when an attorney or an insurer requests what records?
Well, it depends on how that request comes in, and so this is the tough one. I think today most of your requests you're going to get are going to be via email, by fax, or by certified letter or something like that. That's not typically what we're looking for. Now, as they get more sophisticated, they're going to find ways to the attorneys will, because this is what they do. They're going to find ways to request this under the Cures Act electronically. But they're going to have the systems that are going to be able to understand those big data drops, such as XML files. So I think that curve is going to be a bit slower. Now, where we're going to see it more is the patient's going to request it through their app and then share their app with share their app data, if you will, with their attorney. So it's gonna probably change the way that some of that happens. But again, with the patient at the center of the health record, that's really how we see a lot of this generating and doing away with the attorneys actually making those requests.
Okay, so my next question is, can your patient request that you not share their health records?
Absolutely. As I mentioned, the Cures Act doesn't replace HIPAA, right? HIPAA allows your patient to control. And we cover some of this a bit more in that 4th article that I mentioned, the how-to at ilchiro.org/cures, or, through your state association. They may have one very similar to that. And it doesn't replace that ability for a patient to be able to control what gets shared. And privacy still is in play, but ultimately they would have to carve out exactly what they don't want to be shared. But a lot of times, most of these requests are going to probably come from the patient, because remember, the patient is that hub, is that center. Does that make sense?
It does. Okay, so, and this was such a great question when I saw it pop up, because I actually thought of this when I heard your podcast. So there are a lot of clinics out there that use EHR software, but they still have paper charts that they have to rely on when EHR software is down. So how do they need to address that when they have both electronic records and paper charts, or they still have paper charts that for patients who are now on electronic health records, but they haven't scanned in those old charts?
Yeah, and that's okay. So, because the Cures Act and the information blocking applies only to the electronically stored health information, right? So anything that's paper, really, it's still, now, everything is still covered under HIPAA, right? So a patient still has their right of access under HIPAA, right? But under the Cures Act, it only applies to the electronically stored data. So if you're a hybrid office right now and you haven't scanned everything in, and it's only talking about the electronically stored information. Again, very similar to the practice who may be all paper charts, but do all of their billing electronically, right? That billing, that electronic billing portion is still covered, but not the paper charts. So very similar to that.
So this was a good question. Will certified EHRs need access to the patient's choice of apps?
Actually, it'll be just kind of the opposite, really. So the certified softwares will have an API that's pretty standardized. I don't want to get too terribly technical because it is really a technical question. But basically, by the end of 2022, they've got to have FHIR. They got to meet standard FHIR API requirements, which is a healthcare standard. And ultimately, then the apps will have easier access to all of these things. Patients will just key in their credentials to your software that they would have access to through a portal or whatever the case might be, through the patient access portions, which is the requirement under that certification, right? And ultimately, it'll tie it all together, and it'll happen again without that human intervention, which is what we really want. But it's not so much that your software is going to have access to their apps. It's going to be more that their apps will have access to that patient's records in your software. Does that help?
I totally agree. And I have to say, if you think about this, not so much from the provider perspective and that this is change, and change is difficult. Let's be honest. Nobody really likes change. We like it, but think about it from a patient perspective, like from yourself. So I have an app that has all the health records for my entire family and all of my foster kids. And I'm able to see all of their health records. And I will have to say it's been like that for a couple of years because we use the same network of doctors and they have an app for that. But it has been super handy. One of my foster children had to, when she was a baby, had a lot of appointments at the local children's hospital. And it was so convenient to be able to share her records with them from other providers instantly while in the doctor's office, because it saves time and answers questions. There's no guessing. It's huge. Like how super convenient it is. Not to mention, I say this all the time, I love apps. Every clinic should have an app. So like my child's primary care physician, if he has to go to the doctor for a checkup or something and we owe a balance, it sends me a text message and says, click here to pay. And I love that convenience. And
that's it. The more convenient that the apps get, right? The more convenient that they get, the more used they're going to be. The more used they are, the more this is going to apply. I saw a question there from Dr. Loperfido. Hopefully I pronounced that correctly. But I'm going to Dr. Damon. But I probably butchered it. If I did, hopefully you'll give me some grace there. But by the way, he said, there's not an emoji for head spinning. Totally true, right? And some of that's what this is. And so you're like, oh, holy crap, what am I doing? And ultimately, what we start to look at to your question exactly is, remember, it's not replacing HIPAA. It's a mindset shift, right? So instead, you got to say, I've got to share first. So I've got to share it unless I can't really know that I'm not protecting that patient's privacy, right? So if a reasonable person would say, why know that the patient mentioned that they're using this new app. I got the request from the app. I got to know that it came from the patient, right? You have this reasonable belief and then you begin to do it. So, by the way, password's still going to be required because again, a lot of times the API is all going to handle through the credentials of that patient that's accessing, because not all of your data can necessarily be asked. I'm not going to get into the details of where I think some of these requests are going to come because that might be a little bit scary, but it's kind of fun. You can dream a little bit because you got to wonder where the big data is going to come from, right? And so, but from a patient's perspective, that's where we're going to see a lot of the repetitive requests for records. And I think at the end of the day, yes, the credentials and the passwords are really going to be how all of that's going to handhold with that API. But some of that really is HIPAA doesn't go away. And neither do your state HIPAA laws. And that's really important to remember, check with your state association. And if you're not a member of your state association, you should be. I can't. Yeah. And if you're from Illinois and you're not, then I'm really actually just a bit disappointed. Maybe in myself because we haven't reached and talked enough, but give me a call. We'll take care of that. But anyway, I saw another one that I wanted to hit too.
Well, while you're doing that, I was going to say, I posted the link to the podcast and there is a lot about big data. and the benefits of owning our data and how this is so going to be beneficial to the chiropractic profession. And all of you got to drive home today. So click that link, copy it, send it to yourself, text it to yourself, listen to that on the way home. It's like my tradition. Okay, because Jay is my BFF. Everybody knows that. So I listen to every podcast, but it's funny. I love his podcast, but I was doing my Friday night ritual because this new podcast comes out every Friday. And I was doing my Friday night ritual and I was like, oh, good. It's Marc. This ought to be fun. And we weren't 20 minutes into his podcast. I stopped it and I'm texting him and said, let me be the first to ask you because I won't be the last. Please do this webinar for our providers. They need to hear this. But that podcast touches on some things long-term of why this is going to benefit the chiropractic profession in ways we could not even imagine.
Yeah. So and Chrissy, you hit it, right? I'm actually a bit giddy because as an association executive director, there's a couple of things that really come into play for us. One is I want information. I need information, right? So not just when we sit down at the Capitol, and we can talk about that. That's really key. What I don't want to do is I don't want to sit down at the Capitol and say, I've got these research studies. Here's one of 600 patients. Here's one of 1,200. And when they turn into the opposing healthcare professional, if it happens to be something we're opposed on, and they go, well, what do you have? And they go, well, here's a case study of 50 million cases. And now all of a sudden we look like schmucks, right? Because we just had 1,800 versus 50 million. We need to be in that game, but that's not just them. Could you imagine walking into a large provider? Just make up your largest retail provider that you can think of in your head that doesn't cover chiropractic very well. And imagine walking into their senior execs and saying, look, the data is so clear, not just from a health efficacy standpoint, not just from how we get your employees better, faster, and back in and working, but imagine. Look, here's the financial side of this too, because all of this data is going to be so much more accessible and so much more dug down into in the little nuances and details from every different diagnosis code and the different providers that are treating it. Just imagine that big, massive data lake and how it can be used to benefit the profession. Imagine walking into that retailer to those execs. All of a sudden, it has meaning because now we just put our money where our mouth is. Again and again and again, the financial efficacy demonstrates. We've seen that in the studies, but imagine walking in, here's 50 million cases, here's 100 million cases that was studied over the course of 2 years. And all of a sudden, we're off to the races and forget the small little percentages that we're treating now. We're going to have to figure out a way to get people through chiropractic school, right? Because we're going to have patients knocking down our doors. And
yeah, I'm the mother of a future chiropractor. So I will say this too. One of the other things that they talk about and they touch on briefly in that podcast too is if you're already using Infinity as your clearinghouse, we do have many chiropractors in the profession are using them. So we are generating our own data. Jay didn't talk about it enough, and I did get on to him about that. But that data that they've been getting, because Brad is so amazing and has people who are digging into the data, has helped to improve payer reimbursement in so many states. Where they've been like battling these things and showing that there are issues that are, I mean, like y'all just don't even know, like mind blowing. I can't even talk about it. There's also this question that I love because I was going to ask you this and then Allison popped it in here. I received an email from my EHR provider saying they are no longer a certified software and not bound by the Cures Act regulations. How will this impact us?
Yeah. So if you remember one of the how's it going to impact your practice slide just a couple of slides ago, it really covers and says it there. Human intervention equals inefficiency, right? Inefficiency is always an ROI killer in your office. So I don't want, this isn't, again, I don't like to come from a position of fear. That's not really what we're after. It's just understanding, right? So the understanding quotient says this, that if you have to touch it and you have to do a negotiation with a requester every single time you get a request, and it has to be done by a person, which it will, guess what? That's inefficient. And so how will it impact you by not having certified software? Ultimately, you will be less efficient. And it's just a matter of fact. And I think eventually what we're going to see is a lot of the EHR companies are going to step up, and make the move to electronic. Or to certification. I really do believe that because it's too important for the profession to walk away from. But that's ultimately how it will impact. Does that answer her question, you think?
It does. So what I was going to ask you, which this isn't surprising because you and I did talk about this, before she popped that up there is, So not everybody's heard from their EHR software. And what
Yeah.
questions should they be asking regarding certification and being, you know, electronically transmitting records?
It's very important to ask them, and you have to be very, very specific with the question, right? Because are you certified? Well, some of them are certified, but they're not Cures Act certified. Okay. And so that's the question. Are you Cures Act certified under ONC? The second question is, and this will tell the answer, because if the answer to one is yes, then the answer to two must be yes. The second question is your API ready? And the third question is, if all of that's true, do you have training to show us how that we can put this into play for our patients? And that one's key, because you don't want to have all this cool stuff, right, and be able to use it, but not be able to use it because you don't know how. And so the training portion is critical as well. How can we do this? And by the way, if you have software that isn't certified, then the questions that you would need to ask are, what is the largest amount of data that I can download in a data format, not in PDF format? This is really important. PDF is nice for us to look at, right, as people, but that's not what this is. This is about the transferring of electronic health information from one system or one computer to another computer. So it has to be computer readable. So the question is how can I download? Now, I know that some of the chiropractic-centric EHR softwares out there do allow for download of XML files. I've seen it. I know it. I've actually talked to some of their key players, sat down with some of their CEOs and some of their key players that have we actually do it while we're on the phone. And so I know it's possible. Some of them do. But again, the problem with that is it requires human intervention. The beauty is if you've got the full certification with the API, we're so much more efficient, right? And it's a higher ROI, and our patients are happier because now we are playing on an equal playing field, and we actually have parity. And we're not just wanting it, but we're actually achieving it.
So this is interesting. And so Marc and I have been talking about this for a couple months, and we have talked to various EHRs as well. So don't immediately freak out if somebody tells you that they're not Cures Act certified, because some of them are working on it. So if they tell you no, then you can ask them, are you working towards your certification? Because there are several of them that are not, but they are working on their certification.
Yeah, when? That's a follow-up. And I should thank you, Chrissy, for pointing that out. So that's an important piece too, right? If they answer no to those, then say, are you planning to, and when? And I think those are key questions.
They are.
And it's important to know.
So, on the EHR companies, my concern is DC's getting out of the contracts if they want to switch. Termination clauses are long and expensive. Does the Cures Act have any out for them to be able to switch companies if the EHR company is not compatible?
Yeah, so as of 12/31 of 2023, they're required you to be able to download. Can there be a fee potentially associated with that? Yes, but it has to be small. The key is this: any kind of barrier to the release of information, if it's a barrier, right, a true barrier, that's information blocking. It's really that simple. And under this provision, that's where some of this, that's why they've put a lot of this in. And that's why they have these requirements. You can go back and glance at your notes. It may be too small, but you can find that ONC timeline chart. It's really cool. But you can see all of the requirements, and you'll see the vast majority of them are actually for IT developers of certified health IT. And you'll see that 12/31/2023 deadline for download. The answer to your question is some of those provisions are just going to have to be modified, and they'll go away because it's too key. It's too important, because what they want is what they have said they want. And so in your research, if you were to really dig into this, you'll see what the ONC, what the legislature, what the law really wants is they want these EHR companies to be competitive. They want them to battle a little bit, because the more competitive they are, the better product they're going to put forward for you. And so the easier it is for you to switch, right? If somebody's got you locked in and handcuffed, it's hard to switch, and it's tough to get away from, right? And I don't envy them, by the way. And hopefully I'm not coming across as I'm negative to the EHR companies. That's not it. It couldn't be further from the truth. I've had great conversations with people who really love the chiropractic profession, who are trying to find their place with this, right? Because it's not cheap. And so I would ask you to also be patient with them. understand that they're going through this struggle too and trying to figure this out. Do I think it makes us any less diligent and any less demanding? No, but I think it has to give us and allows and requires us to be more graceful and understanding of what it's going to take for them to make this work. And so I would ask you to be gracious to them too in this process, because it's going to be a bit of a challenge. But yeah, Dr. Kim, it's gonna give you some of the ability to be able to modify those and digging into all of this to make sure that what we were saying was accurate, and what we were coaching our members on here in Illinois was at the highest amount of accuracy and gave them the wealth of information they need. So.
Yes, she's pretty awesome. She is the healthcare attorney for the Florida Chiropractic Association.
Perfect.
Phenomenal.
I love the FCA. They're fantastic. Deb does such a nice job down there, and their entire team is fantastic. And again, I could keep going on. I could just go state by state for all of the people that are on with each of your states and talk about how awesome that each of the state associations are. And I will just tell you, I deal with a lot of them, and especially through Chiro Congress, which represents a lot of them on a national scale, if you will. And your state association, you have no idea how much they do for you, and they have no idea how much they love you as a doctor and love you and love this profession and the amount of time and effort and energy that they put in. I promise you, you don't have a clue. If you're not a member of your state association, if you're not guilted into doing it, do it for your own personal ROI. I promise that if you're there, you will see a return on that investment tenfold. I promise. It's going to happen because the state associations are that important to the profession.
So true. And we are we have Colorado is here. California is here. So we have another question that came in. It was a private message. It said, we keep personal notes in the chart about the patient, for example, psychosocial or obesity. And if the patient reads these notes, how do we deal with them being upset? Well, at any point in time, somebody can request their own health records. So they can see that at any time.
Actually, Dr. Erica, because I'm not going to try the last name because I'll butcher it, I promise. But so interesting when it comes down to some of the psychosocial things. I don't have really time to get into the weeds, but there is an exception that helps with this. But you have to be able to carve out some of the records. But this is really important. Not sharing the records with someone because you believe that they will have emotional harm is not a reason to prevent them from seeing the records. That is absolutely a foundational understanding of the Cures Act. In fact, it has to require the preventing harm exception is it, and it has to actually create physical harm for someone, whether it be physical harm for the patient or someone else in their life. There has to be physical harm imminent as a result of releasing those records. Emotional harm isn't a good enough standard to prevent it. In fact, the oncologists are really struggling with this because, of course, they like to look at the patient in the eyes and let them know what they found in their scans or whatever the case might be, especially those that may have had reoccurrences. And that's some of the challenges that we're faced with, right? And so understand that what's really important is that most of the time, emotional harm isn't going to cut it. And you're still going to have to release that information. You have to believe that there's going to have to be physical harm. In fact, you have to believe that there is a substantial reduction in risk to physical harm. Are you
okay, guys? So we're having a tornado, so I gotta go.
I wondered if that wasn't the case. So yes, I think we can wrap it up. Anything you need, go to ilchiro.org/cures. And Christy left another link in there too, and you can jump that way and see everything that's out there. But Christy needs to go and get into a safe place.
I do. I need to go hide out. 20 minutes ago, I had my son come down. He's homesick today. And so the pets and the kids have been in the safe place. Now I got to go join them. So guys, it's been a pleasure. Thank you for joining us today. We will see you here next week. We have another guest, but I'll send you an email about it. Bye, y'all.
See you, Christy.